everyone. Firstly, I'd like to thank the organizing committee of the 12th International Workshop on EUS and Medicinal EUS for inviting me to give a lecture. My topic today is how I do EUS.
Ready? Start. Next presentation will be by Dr. Pradermachai Kongkam. He is from King Chulalongkorn Memorial Hospital, Bangkok, Thailand. He will be presenting how I do EUS-guided GJ. And the session will be moderated by Dr. Avinash Kumar, Mahavir Arogyam Sanstha from Patna. Thank you.
Everyone. Firstly, I'd like to thank the organizing committee of the 12th International Workshop on EUS and Medicinal EUS for inviting me to give a lecture. My topic today is how I do EUS-guided gastrostomy. I will spend about 15 or 20 minutes on this topic. So I'd like to start with this landmark publication led by Professor Takao Itoi, that he wrote a nice manuscript of using a special design balloon to perform EUS-guided gastrojejunostomy. As you are seeing in this figure, that once we drop the EUS scope, then Professor Takao and his colleagues from many press experts around the world, EPASS especially designed the EPASS balloon. EPASS balloon has a first balloon at the farther end of the insertion tube, and the other balloon at the proximal tube, and then endosonographers will insert both balloons and flush the area in the small bowel in the middle between both balloons with the saline plus methylene blue, and then they can demonstrate endosonographic view of dilated small bowel through the linear echo endoscope, and then after that perform a standard EUS-guided puncture procedure and dilate the tract and deploy the stent to connect from the small bowel into the stomach. So that's so-called EUS-guided gastrojejunostomy with the EPASS balloon, which is very special designs. And I like to thank Takao and all my friends named on this study very much for inventing this procedure, because with the EPASS balloon, to my opinion, it's very safe to perform EUS-guided gastrojejunostomy. And according to the result of this study, the authors performed EPASS in 20 patients, and the technical success was very high, it's 90%, and no serious adverse event. So that's convinced us to accept EUS-guided gastrojejunostomy to our routine and practice. And if for the stent that we will use to connect small bowel into the stomach, I would recommend lumen opposing metal stent. And to my opinion, we prefer the hot system over the cold system for the procedure of the I prefer 15 or even larger, like a 15 millimeter diameter exhaust of the boson, or the 16 millimeter of the sparsus, And then the delivery system, I would prefer hot over cold system because it makes a procedure safer to my practice. And if you look at the literature comparing between gastrojejunostomy versus duodenal stenting for palliative bypass of gastric outlet obstruction. This study published in 2021 in EIO, and then this systematic review recruit 5 studies, including 659 patients. With the technical success of EUS-guided gastroenterostomy was 95.2 versus stenting 96.9%, which is not different. And clinical successes was also different, not different, 93 versus 85%. However, in gastro and gastrojejunostomy, the reintervention rate is just 4%, whereas duodenal stenting was quite significantly higher at 23%. So that's the benefit of EUS-guided gastrojejunostomy, which, I mean, in common sense, is clear because it's a bypass procedure, which doesn't need to fight with the area of the obstruction. And the adverse event rates of both procedures were comparable at around 10 and 19%. Let me show cases in my practice. Unfortunately, that the EPASS balloon is not available in Thailand. So the way that we do EUS-guided gastrojejunostomy in Thailand, we didn't use the EPASS balloon to do that. So let's start with this case. This case is a patient of one of my patients, which has malignant hilar biliary obstruction. So then we start with the EUS-guided biliary drainage with hepaticogastrostomy. First, we identify dilated bile duct. We pass the needle in. We pass the guide wire in, inject the contrast, and then we dilate the tract, and then make sure that we control direction of the guide wire device and also appropriate segment of the liver very well. And then finally, we deploy the hybrid stent connecting from left intrahepatic bile duct to the stomach. So then we have performed successful hepaticogastrostomy for drainage of the bile duct obstruction very well. The problem is that the patient still has gastric outlet obstruction. So the bile fluid drain from the liver segment, they come through the stomach, but probably they couldn't go into the small intestine very well. So then we have to do another procedure, which is a gastrojejunostomy. We pass the nasobiliary tube into the small bowel, and then we flush small bowel with the saline plus with water plus methylene blue, and then we make the small bowel dilated enough to be demonstrated with the endoscopic ultrasound view, and then we puncture with the hot system lamps, and then we gradually open farther end of the lamps, and then we open the proximal ends. So then we're done. And once we get into the right place, in addition to be confirmed with the fluoroscopic view and also endoscopic ultrasound view, we also able to see the methylene blue dilated fluid across the lamps. So that's confirmed patency of stent connecting from small intestine to the small bowel. And if you see in my fluoroscopy view here, before the gastrojejunostomy procedure, we use the standard gastroscopy and procedure, and we place the either 8.5 French nasopharyngeal tip or 7.5 nasopharyngeal trend across the area of the obstruction into the dilated small bowel part, and then we flush water mixing with the methylene blue to make the small bowel dilate. That's a technique that we use in our institute. So then in our institute, Sometimes we see double obstruction combining bile duct obstruction and distal bile duct obstruction and gastric outlet obstruction. And actually, this double obstruction or combined obstruction had been classified and mentioned by Nagai, published in and Professor Isayama, published in 2017. There are 3 types of combined biliary and duodenal obstruction. Firstly, area of duodenal obstruction is higher than ampulla area and same level and farther than the level of the ampulla for duodenal obstruction. And actually, the treatment of double obstruction can be treated by double surgical bypass or ERCP plus duodenal stenting. And Nagai and Professor Isayama recruit studies using combination of ERCP or PDPD plus duodenal stenting and reported technical successes is quite high, more than 90% in most series with the low complication rate. It's still good, but if we compare, if you have choice of surgical hepaticojejunostomy versus gastrojejunostomy in patients with advanced stage cancer, it looks like not appropriate and too much, maybe more invasive in this clinical scenario. You use ERCP plus duodenal stenting, even though technical successes was reported very high, but everyone knows very well that technically it's very difficult because you push, you place the ERCP scope in a very limited area to place the biliary stent in, and even though you have successful placement of both stent for ERCP stent and duodenal stent, then again they might block each other and cause a blockage of the stent earlier than we anticipate. So then probably choice of combination of EUS-BD for EUS-guided jejunostomy may be more appropriate and may provide longer patency time of both stent in comparison with the ERCP and duodenal stent. However, no study has compared and reported that kind of result at this time. So, but if we compare versus EUS-BD versus ERCP in patients with distal biliary obstruction, at least 3 comparative trials show better 3 parameters of EUS-BD over ERCP. Those 3 parameters were stent dysfunction and post-procedure pancreatitis and tumor inflows, which EUS-BD is better than ERCP with biliary stent in patients with malignant distal biliary obstruction. And I like to show another case. This is the patient has ampullary mass and causing both duodenal obstruction and bile duct obstruction. So then what we try, at the first time we try ERCP, but we couldn't because of very large ampullary mass. We couldn't get a successful cannulus. So then we start with EUS-guided choledochoduostomy, identify the dilated bile duct and puncture the needle in and press the guide wire, inject the contrast, and then we finally place the lamps with the cold system to bridge distal bile duct and duodenum. So the CDS procedure has accomplished. And then we start with the gastrojejunostomy. As you see in this one, we use the scope to place the nasobiliary tube from the small bowel below to the obstruction of the duodenum. I would recommend the gastroscope, but this case, because we just finished EUS-guided bleeding procedure, so we continue with the echo endoscope, which we can do. And we press the nasobiliary tube in the small intestine, and then we flush with the water mixing with the methylene blue and make the small bowel dilated enough for us to see with the echo endoscope. So then we pass with the hot system lamps, puncture in, and then we open. I will show you one more round since at the beginning of the puncturing. Now we see the dilated we pass the needle in, we open, and we retract until the farther end close to the small bowel wall, and then deploy from the gastric side. And then we have a successful EUS-guided gastrojejunostomy procedure. So, yeah, in this case, the video was reported in Endoscopy 2020. If you are interested to review again in more detail, you can go for that. And we have another case of patients with malignant biliary obstruction and invasion through duodenum and cause supra-ampullary duodenal obstruction. So in this case, the patient has both obstruction and mass in the hilar area with extension into the lower area as well. We couldn't pass the scope into the duodenum. So then we switch to double EUS drainage procedure. We start with EUS-guided gastrojejunostomy. Press the nasopharyngeal tube over the guidewire into dilate the small intestine, make the small bowel dilated, and we use the hot system lamp scan puncture in, open the farther end, retract it back, and pull the scope back a little bit, and open the proximal end. So we're done for the gastrojejunostomy. And then we continue with the hepatico-gastrostomy procedure. The principle is almost the same for EUS-BD. Identify the dilated segment and puncture in dilated tract and deploy the stent connecting from the left intrahepatic bile duct to the stomach. So then we accomplish both procedures within a couple hours. And these three cases we done smoothly and no procedure-related adverse events after the procedure. And the procedure can resume food within a couple of days. They can go back to their home with ability to eat, and jaundice resolve on later days. So that's why I think that my conclusion for this lecture is that if you see the patient with gastric outlet obstruction and also combining with bile duct obstruction, EUS-BD plus gastrojejunostomy becomes an interesting option to resolve problem of patients, but no outcome data yet. That's true. And EUS-BD has some advantage over the ERCP in malignant distal obstruction, as I show you. And EUS-guided gastrojejunostomy has lower re-intervention rates than duodenal stenting. Yes, that is. And however, if you want to perform therapeutic EUS, particularly EUS-BD and EUS-guided gastrojejunostomy nowadays, I would strongly recommend you to get trained under the expert. We don't want to risk the patient for this potentially harmful procedure. But with the proper techniques, with the proper hands-on training, and under the hands of the expert that you will become in the future, the patient will have benefit of EUS-guided gastrojejunostomy. And if they have both obstruction, they will benefit from combination of EUS-guided gastrojejunostomy and EUS-guided BD as well. So I like to thanks again, once again, thank organizing team for inviting me, particularly Malay Sharma, my friend who organized this wonderful meeting. Thank you very much.